If you live with severe sweating, you already know the daily routine: wiping your palms on your jeans before touching a keyboard, leaving sweat marks on important paperwork, or watching moisture rapidly pooling on your phone screen as you try to type. The physical friction is annoying, but the social cost is exhausting. They actively avoid handshakes, pull back from basic physical contact, and pass up career opportunities just to avoid the anxiety of being noticed. This specific condition is called primary hyperhidrosis. It happens when your sympathetic nervous system misfires. There is no underlying disease causing it. Your nerves are simply sending an ongoing false alarm. Looking at the upper body's anatomy, the sympathetic nerve chain goes into overdrive. It blasts signals to the sweat glands in your hands and armpits, forcing them to produce a volume of sweat that far exceeds what your body actually needs to cool itself down. This pattern usually begins in childhood or adolescence. It is entirely different from secondary hyperhidrosis, which is triggered by external health factors like thyroid disorders, diabetes, or hormonal shifts. Because primary hyperhidrosis is a hardwired structural misfire, you face a tough choice. You can endure the ongoing social isolation or start climbing a ladder of medical interventions designed to force an override of that faulty signal. Doctors approach this using a treatment ladder. As you step up from basic to advanced options, you gain efficacy, but you trade away comfort, accepting higher risks of side effects at every tier. This comparison matrix maps the options. Step 1 starts with clinical strength prescription antiperspirants. They attempt to create a mild surface-level blockade over the sweat glands. The results are limited. While they work for mild cases, they often fail entirely against heavy hand sweating. Worse, the high chemical concentrations frequently cause severe skin irritation, itching, and burning. The next step relies on oral medications called anticholinergics. These drugs work systemically, absorbing into the bloodstream to dampen the nerve signals that trigger sweat across the entire body. But that broad suppression comes with a high cost. Patients routinely experience severe dry mouth, constipation, blurred vision, and elevated heart rates, making long-term adherence nearly impossible for most. When pills fail, doctors turn to Botox injections. It is highly effective at temporarily paralyzing the local sweat glands, producing excellent localized results, particularly for underarm sweating. The downside is the intense maintenance. The relief lasts only a few months, forcing patients to endure painful, expensive re-injections several times a year. In the hands, Botox can also seep into delicate intrinsic muscles, causing a noticeable temporary weakness in your grip. These conservative treatments are all reversible, which is safe, but it traps severe sufferers in a loop. You are left paying a continuous tax of recurring costs, localized pain, and systemic side effects, forcing many to seek a permanent exit from the latter. When the latter fails to provide a livable solution, the medical pathway shifts to intervention. This is where endoscopic sympathectomy, or sympathectomy, enters the picture. This chart compares long-term outcomes. While conservative methods frequently fall short over time, surgery delivers a permanent cure rate of 95 to up to 98%, specifically for palmar sweating. The operation itself is a highly specialized functional thoracic surgery. It is minimally invasive, performed using a tiny camera inserted through openings in the chest that measure only a few millimeters. Inside the operating room, surgeons make a critical technical choice. You will see two terms used interchangeably, but they describe different anatomical methods: sympathectomy versus sympathectomy. Looking at the left side of this anatomical model, a sympathectomy involves excising the chain. A segment of the sympathetic nerve node is entirely cut out and physically removed from the body. On the right side, a sympathectomy takes a different approach. The surgeon makes a clean slice to sever the signal pathway, but the central nerve node itself is left intact. In recent years, leading global centers have heavily favored sympathectomy. Slicing the pathway rather than extracting the node minimizes internal surgical trauma while maintaining the exact same high rate of stopping the sweat. Do not let the small incisions fool you. This is an irreversible, permanent disablement of the specific nerve signal traveling to your hands or armpits. Surgery definitively breaks the expensive, painful cycle of temporary fixes. But accessing that relief requires fully accepting an anatomical alteration and the long-term consequences that come with it. The most common and intensely debated consequence is compensatory sweating. If you shut down the sweat output in your hands, the body still has to regulate its temperature, so it redirects that moisture to other areas. Typically, this new sweating emerges on the back, the abdomen, or the thighs. This probability distribution clarifies the actual risk. Experiencing a minor volume of compensatory sweating is nearly certain, but the risk of developing heavy, disruptive sweating that ruins your clothes is statistically much lower. Some patients also deal with excessive dryness. Once the operation succeeds, the hands can become so dry that they require thick, daily moisturizers to prevent the skin from cracking. Because surgeons work inside the chest cavity, there is a risk of pneumothorax, or a collapsed lung. It is uncommon, and if it does happen, it is easily managed by the surgical team in the hospital. There is also Horner's syndrome, a severe complication affecting the nerves that control the eye. However, when surgeons accurately map and stick to the correct thoracic nerve levels, this outcome is exceptionally rare. Choosing surgery is not about chasing flawless biology. It is a calculated trade-off. You are deciding if the guarantee of perfectly dry hands is worth the high probability of a damp back on a hot day. Institutions like the Thoracic Surgery Unit at Cairo University recognize this exact trade-off. Their clinical focus extends past simply drying out the hands to actively mitigating those long-term complications. To achieve that, they utilize an advanced approach called bilateral staged selective dorsal sympathectomy. The philosophy here discards blind, generalized nerve cauterization. Instead, surgeons map the specific patient's anatomy to pinpoint and carefully select the exact nerve level responsible for the target area. They also employ a staged strategy. By intervening on just one side first, or separating the operation into sequential stages, they dramatically compress the risk of severe compensatory sweating while protecting the high success rate. Even with advanced techniques, this surgery is not for everyone. If you have mild sweating, if your sweating is a secondary symptom of another disease, or if you sweat heavily across your entire body, surgery will not solve your problem. The ideal candidate is highly specific. You should consider this if you suffer from severe primary sweating in your hands or underarms, if the condition dictates your daily choices, and if you have fully exhausted the medical treatment ladder. Living with severe hyperhidrosis carries a heavy daily tax. You do not have to pay it forever. Endoscopic surgery should never be your first step, but when the latter fails, it offers a definitive final step to taking back control of your life.